Good afternoon, everyone. Welcome to Christian Medical College Medicine Annual Conference 2023. We'll be starting with the oral virtual presentations. So our judges for today are Dr. Sebin George, who's an Assistant Professor of Pediatrics, Christian Medical College, Vellore, and Dr. Shaini Khaki, who's a Public Health Physician in Medicine Science Frontiers. We welcome both the moderators for the session. The first presentation by Dr. Shreosi Thomas.
Greetings of the day, esteemed panelists. My name is Shreosi Thomas, and I'm currently pursuing MPH in Health Administration from Tata Institute of Social Sciences, Mumbai. The topic for my study today is accuracy of an artificial intelligence-based symptom checker in a primary care context and the system to access care before a diagnosis in semi-urban India. So to give you a brief introduction, as we all know, healthcare has significantly benefited from AI in terms of enhanced patient care, diagnosis, treatment, and overall healthcare administration. Digital online symptom checkers and patient-facing triaging tools are all the rage now. These tools enable users to enter symptoms, respond to questions, and either receive a potential diagnosis or the guidance of the amount of care that is required. Machine learning and AI are frequently cited as potential ways to enhance triage systems greatly. Such systems may also have the capacity to recognize life-threatening conditions in cases of heart failure or stroke and prompt the patient to seek emergency medical care. In a study done by CMC-MAC et al. In 2020, it was found that these tools have significantly impacted the demand for healthcare services in terms of diminishing it because now fewer people are likely to access these services in less serious conditions that could be self-managed. Now, when we talk about Nidian, which is the AI-based tool that I used during this study, it is an application that provides a differential diagnosis to the symptoms that is entered by the patient. Now, the algorithm that this Nidian uses is that it uses the inputs to generate a differential diagnosis, and that directs the best triage choice wherein an emergency visit is prioritized for any ailment that poses a life-threatening risk to the individual based on the symptoms, risk factors, and the diagnosis that is obtained. These are the following features of Nidian, where it gives the diagnosis as explained earlier. It also provides suggestions of confirmatory tests and examinations where the patient, after doing the specific tests, can update it into the system and the probabilities are then analyzed again. Then it also has the capability of handling concurrent diseases, provides an objective decision support, and gives opportunity to the patient to have like a direct interaction with the front end of the system. Now, if you see the literature, in the past, studies have been done, but the accuracy of doctors against digital symptom checkers was done in US in 2016, where it was found that doctors were more inclined to rank accurate diagnosis first in case of high acuity and unusual vignettes, whereas symptom checkers were more likely to list the proper diagnosis in terms of low acuity and common vignettes. Also, in a study done by Maghrabi in 2019, it was concluded that these triage systems need to be more studies need to be done to understand the accuracy of such systems, because even though certain studies have found that these systems may or may not decrease the load on the healthcare system, it is advised that more studies need to be performed in this particular context to have better clarity. Hence, the rationale of the study lies here, where no such study has been done in India yet. And my study was done with the following objectives, wherein I tried to assess the accuracy of the application in correctly diagnosing the patients, and to understand the factors affecting the healthcare seeking behavior in the population, and to explore the perception of technology and AI. Now, talking about the methodology, it was a cross-sectional mixed method study wherein I took in people from all age groups in Asansol of Paschim Bardhaman district of West Bengal. My sample size was 67, wherein I used purposive sampling from the sub-centers and PHCs and private clinics of the nearby semi-urban areas. Out of the 67 people, 15 people agreed to be interviewed and gave consent. Now, the data collection was done with the help of questionnaire, wherein vital statistics, past medical history were also taken into consideration. And a semi-structured interview guide was done to do the qualitative part of the study. An in-depth interview was conducted, and the application of app was done to test the accuracy. Now, the data analysis, in terms of data analysis, the triage decisions were compared with the diagnosis that was made by the doctors to test the accuracy, and the quantitative data was analyzed using SPSS and qualitative using content analysis. The ethical considerations were in place, wherein I acquired informed consent, and the interviews were conducted in a private atmosphere. Now, if we go to the findings and analysis, so this was the demographic profile of the patients that were in the study, wherein the majority of the patients were in the age group of 41 to 65 years, of about 40.3% patients in that age group. And females predominantly were there in the study, wherein they had a percentage of 68.7%, wherein males were around 31.3%. Now, if we see the accuracy of the app, on the left-hand side, we see the pie chart, wherein we have put that around 46.3% of the cases were diagnosed correctly, and 11.9% were inaccurate, and in 41.8% of the cases, the accuracy could not be checked due to various reasons like lack of reports, follow-up, lack of final diagnosis that was provided by the doctors, etc. Among the inaccurate cases, it is important to note that majority of such cases were diagnosed to be of heat exhaustion and heat stroke, which was not in the list of the diagnosis which was generated by NIDIAN. When inquired about that with the developer, it was found that since heat stroke is a very uncommon occurrence in US, it was not included in the system, but after our inputs, it was included in the system based on Indian needs, and not just heat stroke, a few other ailments were also included in the system. Now, if we see the accuracy among the age groups, it was noticed that majority of the reported illness in the age group of 0 to 18 were found to be accurate of around 69.2%. And but these were minor illnesses. The reported illnesses were mainly of fever, earaches, skin rashes, etc. Now, when we try to understand the factors affecting the health-seeking behavior and the perception of technology and AI, the following sub-themes emerged. In health-seeking behavior, the behavior depended greatly on the perception of severity of condition by the individuals, wherein they considered themselves to be sick only when they were bedridden. And next was the dependence on alternative system of medicines like homeopathy in West Bengal and over-the-counter medicines that they usually take when somebody is sick from local pharmacies. It was also seen that health-seeking behavior seemed to be lacking in men, where they procrastinated it on account of work, long waiting times, etc. Also, like I mentioned, that the West Bengal health system depends largely on homeopathic medicines as well. And when it does not subside with that, a person reported that they get OTC medications from the local pharmacies. Next up, when we talk about the accessibility of healthcare services, when we asked the people if they would prefer to have a solution like this, where they can put in their symptoms in their smartphone and try and get a diagnosis and get preliminary care, they said that it would be great to have something like that. And the women that I interviewed, they also portrayed about how they cannot access healthcare services unless and until their husband is at home. Hence, gender norms, the gender roles that the people play also came into the picture, wherein the women are dependent on their husbands to seek healthcare. And also they said that they do have a smartphone with them. So in case some solution like that could be provided, that would greatly help them in seeking healthcare at the correct time. The next theme that emerged was the belief in online solutions. So majority of the people had some apprehension towards trusting a computer's diagnosis against an actual doctor, because according to them, the doctor there knows them since ages, but the app cannot match that. Also, the language barrier came into the picture, where they expressed their concerns, where they cannot understand English properly, and these apps are mainly in English. So how will they use the app if they cannot explain their symptoms in English at all? The final theme that emerged was the cost of online solutions, wherein I asked them if they would prefer paying for a solution like this on their phone. To which they said that if it is provided free of cost, like Google is free of cost, then they're okay to use it. But otherwise, they would not prefer. And if at all, if they have to pay for it, they would rather go to a doctor rather than getting a computer's diagnosis. So, to conclude, I would like to reiterate about how Nidian was able to diagnose 46% of the cases correctly, and 11.9% of the cases were accurate, with 41.8% cases which could not be checked. And again, how the accuracy of diagnosis varied across the age groups, with the highest being in the age group of 0 to 80. Hence, through this study, it can be said to some extent that patients can use these AI-based symptom checkers to understand their symptoms and seek preliminary care before seeking proper formal health care. Now, these assertions need to be verified with further big-scale research, and it could be finally concluded that AI-based triage decision support may improve patient outcomes in terms of helping them with seeking preliminary care, save their healthcare expenditures, and streamline access to healthcare in the long run. Now, these were the limitations of my study, wherein I checked the accuracy of the application based on individual physician's decision. Hence, the variability in the individual decision comprises the study's primary limitation. Also, another major limitation is the small sample size of the study. These are my references. Thank you.
Thank you for that fascinating talk. If no one minds, I would like to ask the first question.
Yes.
So you mentioned the purposive nature of your sampling. I would like to know how many of your sample is from an urban educated background or a rural poorly educated background. I'm just concerned about the generalizability and the reach of this intervention.
Right. So, ma'am, I actually interviewed people in the rural area only, like on the outskirts of Asansol, where Asansol is a semi-urban place. But I went to the outskirts and I tried to access people from the nearby villages, and was mainly talking to people who were seeking healthcare from the health and wellness centers of that location or the primary health centers. So they were educated till 9th or 10th standard mainly, but not beyond that. None of the participants were educated beyond that level.
So I will just start off by reading what Dr. Veena Shatukna has put in the chat box. Elbin, can you just scroll up? There is a couple of comments in the chat box. Yeah, so Dr. Veena Shatukna has commented in the chat box mentioning that AA needs tech and there is poor understanding of patient's background in terms of class, caste, etc. And that women will, sorry. Women will find it impossible to use AI since they have non-specific symptoms due to work, lack of sleep, poverty, and domestic abuse. So I think whenever we use technology, it's very important to understand the context in which the technology is used, because what is relevant in one part of the country may need to be adapted before it is used in another part of the country, another part of the world. So that part I think is not addressed in the study. So that is something probably that you can look at if you are considering future research with AI in terms of how relevant it is to the context. Other thing is, I wanted to ask, when you had these interviews, were you able to assess if anyone of them faced any unnecessary stress, or was there a lot of self-medication because of diagnosis by AI?
These health and wellness centers, they catered to the nearby villages only. So they had access to healthcare in that area, but only the women said they can't access. So unnecessary medication, not so much, but yes, they depended largely on homeopathic medicines, not allopathic, any medicine. They won't take allopathic medicines without consulting the doctors or the nurses in the health and wellness centers. So they had access to healthcare, but the government facilities alone.
No, I meant specifically in terms of this AI use. Let's say that AI gave a particular diagnosis. So did that lead them to go and take a medication which they otherwise would not have taken? Homeopathic
Sir,
they're anyway
yes.
taking, right? So
Yes, sir. Yes, sir.
in
So
relation
this, no, sir. I actually interviewed those patients who came to the health and wellness center. Like, I did not want them to take unnecessary decisions based on the what, because this is still in the testing phase. So what I was doing is they were seeking help from the doctor, and side by side I took their permission. I was like, would you be willing to share your information with me as well? This is my study, and I have been trying to understand if it is diagnosing accurately. So that is when they were so it was not like that whatever the AI diagnosed, they were seeking medications or anything from that. So I was just trying to test if the diagnosis is correct or not. So yeah, it was happening side by side, and I was cross-checking it with the doctor. The diagnosis what AI was generating and what the doctor finally could diagnose.
And from what I understood, it's not validated in India, right? It's developed elsewhere, but it's yet to
Yes.
be validated in developing nations.
Yes. So this is part of my summer internship that I'm doing with a startup called Upaya Health, where they're trying to bring this AI-based application to India. But for that, they need to test it first, if it is able to diagnose correctly and to what extent. And it is authorized by BIRAC stage 1 startup. So that is why I was testing.
So one suggestion would be that when you're working, it's part of your internship, it would be good to mention it as a disclaimer. Since you're working with the
Right.
company that is using the tech, it's good to mention it as a disclaimer.
Right. So
Sorry, I have one more question, Shreosi. In the current climate, when we're increasingly encouraged to think about health as a lived experience rather than disease positivity or disease negativity, how relevant do you think an intervention like this is to the poorly educated or the rural or people that don't have access to technology? And even in urban areas, if an app could cure you, especially for minor medical illnesses like you suggest, you're not at risk of severe morbidity, like no one is freaking out about a cold, but it's more about the lived experience of a cold that we would like to treat and intervene from. So do you think it could, in your literature review, I'm curious to know what themes have arisen. And I was wondering if the research and your literature review point towards replacement of the human-to-human interaction as something that is acceptable or not. If it was Google, people would be Googling their symptoms and there would be no doctors. So I was wondering what your literature review says and what your current research triangulates with that review.
Right. So basically what we were trying to do is if it is able to diagnose the life-threatening conditions where they need to seek immediate care. So our main goal was to try and ascertain that. So the thing was that most of the cases were not very severe. So we could not find any such cases, but in some cases it did diagnose that, but we had accessibility to a doctor. So it was not an issue, but our main goal was that so that people could seek healthcare like on a prompt basis. If they are anyway, a lot of us do Google our symptoms, those who are educated, like you mentioned. So yes.
Do you think an AI generated intervention could be a worthy replacement for a human-to-human interaction, especially in a context in which we are encouraged to think of health as a lived experience, as a holistic experience, rather than disease positivity and disease negativity?
Sorry, ma'am. I was not able to.
Oh, I was wondering, do you think an AI-generated intervention is a worthy replacement for the human-to-human interaction in a context in which we are increasingly encouraged to think about health as a holistic lived experience rather than disease positivity, disease negativity?
It is not a replacement, ma'am, but it would definitely help in reducing the load of unnecessary, like minor cases that is being reported to the facilities. So in that and in terms of life-threatening disorders that they might have, so they can seek prompt care. So not a replacement definitely, but yes, would help the healthcare system greatly.
We're out of time. Thanks a lot, Dr. Shreosi. We will move on to the next. Thank you.
Thank you.
We'll move on to the next presentation by Dr. Sweety Kedia.
This study is assessment of implementation of the Pradhan Mantri National Dialysis Program (PMNDP) in hospitals in Delhi. Annually, 2.2 lakh end-stage renal disease patients are added in India, leading to a demand of 3.4 crore dialysis. To make renal care services affordable to the above poverty line and free to the below poverty line, Ministry of Health and Family Welfare launched Pradhan Mantri National Dialysis Program (PMNDP) in public-private partnership mode in 2016. Aim of this study is to assess implementation of PMNDP and suggest recommendations for improvement. In India, the proportion of CKD patient amounts to 8 to 17% of the total population. About 10 to 20% of those with CKD are expected to develop ESRD. So, a significant Indian population of more than 4.5 billion is at risk of developing ESRD. Leading cause of ESRD disease in India are diabetes and hypertension. Hypertension was reported in 85 to 97% of patients with kidney failure. Through Ayushman Bharat Health and Wellness Centers, government is taking steps to reach undiagnosed diabetics and hypertensives to prevent such cases to progress to more advanced stages, leading to damaging of other organs like kidneys. Still, significant Indian population is at risk of suffering ESRD and may require dialysis treatment. PMNDP covers 36 states and union territories with 1,353 centers and 9,068 hemodialysis machines. From 7 functional dialysis centers in Delhi, where PMNDP is operational, 4 centers were randomly selected. In total, 170 respondents enrolled in dialysis units were interviewed. Primary data was collected through observation checklists and interviews of healthcare providers also. Beneficiary questionnaire was formulated to assess the satisfaction of beneficiaries with quality of dialysis services, cost of services. As per analysis, more than 85% of respondents were BPL card holders. Most patients are out of jobs. More than half had hypertension, about 50% had diabetes, 10% were having both the diseases. About 1/3 of the patients were unaware of their comorbidity. About 60% beneficiaries consulted registered healthcare provider at the tertiary care facilities after experiencing the critical stage of disease. Out of 170 beneficiaries, 108 changed their center. Out of those, 71 beneficiaries found a nearer center, which means 64% beneficiaries shifted to another dialysis center, and out of those 64%, 66% found a nearer location. This data also shows that 100% of the beneficiaries who were traveling more than 30 kilometers for dialysis were able to find nearby center. All categories also got an average reduction in distance ranging from 32 to 87%. This clearly depicts that PMNDP centers are helping people in a big way. But are they really able to reach PMNDP easily? For that, we studied their past center visits. The same is elaborated in the next slide. 65 patients out of 170 could find and visit PMNDP as their first dialysis center. Out of these 65, 59 never shifted to any other private or government facility. This highlights that the beneficiaries were satisfied. And even those 6 beneficiaries who explored new centers were PMNDP only. Not even single shifted to other government, trust or private facility. PMNDP centers were at average distance of 11 kilometers for these 65 beneficiaries. Coming to the total of 170, out of these 108 explored new centers, of which 75 could find PMNDP centers. These 75 beneficiaries reduced their average distance from 15 kilometers to 12 kilometers. Once again, out of these 75 beneficiaries, 72 did not shift their centers and are continuing at the same centers. The remaining 3 beneficiaries explored a nearby PMNDP centers. Lastly, 27 beneficiaries were able to find PMNDP in nearby areas and reduced average distance travelled from 18 kilometers to 12 kilometers. Similar story continued for C4 category. The question which arises is, what took these 109 people to reach PMNDP centers after as their 3rd or 4th center? That points out lack of awareness as a severe deficiency. Out of 108 beneficiaries who shifted to another center for dialysis, 71 beneficiaries could find a nearer facility and reduce their average distance from 19 kilometers to 10 kilometers. Few could find it as second center, few in third, and for some it took the 4th center as well. However, there were 37 beneficiaries who had shifted to a facility which was far away from their existing facility. For them, the average distance increased from 9 kilometers to 17 kilometers. 37 of them belong to other government trust or private facilities. This results in a 2 times increase in distance travel by 20% of the beneficiaries to avail renal care services at PMNDP centers. So, on one hand, where 71 of the beneficiaries could avail services in a nearby PMNDP center, 37 number of beneficiaries had to travel double distance to reach PMNDP centers. They couldn't find a nearby facility even in their 2nd, 3rd or 4th center shift. This clearly shows that the facilities are not well spread and there is lack of facilities in terms of numbers. 67% of the beneficiaries came to know about this program after multiple hospital visits or through relatives, neighbors. No healthcare worker, ASHA or ANM visited to counsel them in community and generate awareness. Dialysis centers are not being fully utilized for the want of patients. The table depicts that out of all the sources of information, digital media was reported as the least prevalent source. Although more than 80% of the beneficiaries had chosen digital media as their preferred source of information while being interviewed. Looking at this table, gender disparity of beneficiaries is evident on face of it with the ratio of 35:65. Active participation is seen by women beneficiaries where shift resulted in decreasing travelling distance. The most eye-opening point validated by the survey was that where beneficiaries had to shift and this resulted in increase of travelling distance, the female ratio dropped down, which means due to the lack of PMNDP centers, female beneficiaries had to drop out. For males, 93% population lies in 22 to 71 years age group, whereas females are 93% in the same age bracket. Similar trend is seen in total age group. But the data highlights that the program is still not able to capture females from age group of 70 or above. We might need to motivate and spread awareness specifically for this age group. Male to female ratio also depreciates as we move high in age group. Probably women in high age group cannot make it to PMNDP centers. The 4 dialysis centers became functional during 2018 to 21 with 35 hemodialysis machines providing services to 200 patients on an average. Up to maximum 40 hemodialysis sessions were conducted daily in one center with fixed days timings for patients. Waiting time is less than 1 hour. More than 90% of the respondents are found to have significant improvement in quality of life. But it was observed that basic amenities like number of seats, toilet facilities, pest control, fans, drinking water, hygiene practices for attendant waiting rooms were not adequate. Placement of AV fistula has to be done from outside facility. About half beneficiaries paid rupees 14,000 on average for vascular access placement. More than 60% beneficiaries use private facilities for diagnostic services. Only one impaneled nephrologist is managing 4 centers, visiting twice in a month for examining beneficiaries. Post of nephrologist has been vacant since long. Medical officer assesses patients during admission and dialysis, attending medical complaints, and the lead technician monitors work of the dialysis center. Effective advertisement marketing of this program on the internet is required. Audio-based mobile application should be developed for educating patients and community which guide the patient regarding availability of free dialysis services at enlisted centers and related information. Dialysis program handouts should be shared with patients. It is essential to increase the number of dialysis centers. Tie up with nearest government health facilities well equipped with free medicines, 24-hour backup power supply, teleconsultation services, sample collection, blood transfusion facilities, vascular access placement, blood and quick referral in case of emergencies with 24/7 ambulance connectivity is required. Also, an effective quality assessment performance improvement program needs to be implemented. Clinical audits should be done. Specialized training course curriculum should be formulated for MBBS doctors posted at the dialysis centers and specifically designed training modules should be utilized for skill-based training of healthcare professionals. Also, encouragement and promotion of research for alternative solutions, novel technologies such as implantable bio-artificial kidney should be done.
Involve donation of dialysis machines to primary healthcare centers all across the world, all across this region. I think I missed that part. Could you clarify for me, please?
Yes, ma'am. The hemodialysis machines, they are being provided by the company only, the service provider. Like government is providing funds to the company, to the private company. It was launched in public-private partnership mode in Delhi region.
So so they basically donate dialysis machines to primary healthcare centers, therefore decentralizing it from super specialty centers into the primary healthcare. And that's how they're increasing equity. Is that what it is?
Ma'am, actually, these centers are being functional in district hospitals currently.
District hospitals, okay.
District hospitals, and wahan pe they are providing, the hospitals are providing the space to the centers, and the service provider, they bring their machines, they bring their staff, and they provide the services. So
I was wondering if your research involved any qualitative data collection of the perceptions of the point of care providers and the perceptions of the patients themselves on their experience of using this service.
Yes, ma'am. Ma'am, I interviewed the healthcare providers also to know their point of view also, because they are also facing many challenges while providing. It's not just the beneficiaries. So I took in care both the beneficiary point of view and the healthcare provider point of view.
So what
Like,
were the main themes that emerged from your qualitative data collection?
ma'am, like the healthcare providers, they this point of providing specialized training, that was raised by them only. That if we get some specialized training, if we get some certification, that would be helpful for us in providing better services. And secondly, yes, they were basically focusing on the training part only. That some refresher training, because it is human nature that even if you have learned, you need to keep it refreshing also. So that was one point they had focused upon. Also, they were this matlab, the utilization, better utilization of the dialysis centers can be done if the staff is recruited accordingly. What I was, matlab, after discussion with them, ma'am, one most important point which came up was ki if the tie-up happens between the healthcare nearest government health facility, so maybe those hemodialysis machines can be used for the patients of the healthcare facility also, and so it can be a mutual thing.
What was the perceptions of the patients in your research about this program?
Patients, ma'am, the most they were satisfied with the services provided by the centers, because most of them, more than 85%, were BPL card holders. So the charge of one dialysis session, 2,500, which is just one session. So in a week there are 2 to 3 sessions, and per month, so their cost of services did decrease significantly because of this program. And also, once they have joined this center, they, matlab, through the data also it is evident they are not shifting to the other centers, to any other private or government facility. So on the and I have, through my questionnaire, I have asked them in multiple ways, like, were you satisfied with the behavior of the staff? And they were satisfied. Like more than 90% were satisfied, even with the behavior, which is so. And there were some challenges also they mentioned, which I have mentioned here, like if the blood sampling services can be included in the program, like if a tie-up happens with the nearest government health facility, and they could get the consultation services, the blood diagnostic services also at the same matlab, because now what they were telling me ki हमें dialysis के लिए for we are going to one center, for medical consultation we are going to some other center, and there's no linkage between them. So it would be better if some tie-up could happen, and specifically for AV fistula insertion, they had no guidance. If they're going to some private centers, the chances of infection are also higher.
Okay, so I think one comment I would like to make, I think it's really good that you looked at the basic amenities, not just the technical part, but it's good that you looked at the basic amenities what are available in the centers. So my question is regarding, can you just put up the slide? Is it possible age group wise? Okay, it's not possible, it's all right. I had noticed that quite a few number of patients were less than 40. There were a significant number of patients less than 40, if I'm not mistaken.
Yes, sir. Yes, sir. Yes, sir.
So many of them.
There's significant number. Matlab, in the higher age group, there were lesser number of patients.
Okay, so it is quite concerning that there are quite a few patients who are in the less than 40-year age group. So were these patients aware that they will have to eventually opt for a renal transplant, or was there a false sense of security because they are going for dialysis, or did they know that they will have to go eventually for a renal transplant? The younger patients.
Sir, yes, sir. Sir, they knew about the consequences, and they also understood their dependency on dialysis. But the awareness part, I have been stressing upon that if the awareness could be improved, maybe we could catch them also less than 40 years. Because this is a chronic thing. It does not affect you on an urgent time limit basis. So maybe, and sir, in the initial phase of the disease, many of the patients did not know about their comorbidities like diabetes, hypertension. So, and they presented to the tertiary care level with very critical symptoms like when they had some loss of consciousness, some seizures, some very critical symptoms. At that stage, they presented to the hospitals, like more than about half of the patients they presented like this. So lack of awareness of their comorbidity and lack of awareness of this program, that can be improved. If this is a good program, but if we want to make it into a better one.
Thank you. Do we have time for any questions from audience? Okay, no questions in the chat box.
I would just like to summarize your take-home message, which is that this program of providing dialysis machines to district hospitals improves accessibility of these services to the primary healthcare catchment area. Is it only accessibility? I know you touched upon themes related to quality of care, quality of life as well, but accessibility, is that the main focus of your study? Am I right in thinking that?
Yes, ma'am. After analysis, the accessibility has come up as a scope of improvement area. Yes, ma'am, you're right. If we improve on the accessibility part, on the awareness part, accessibility and awareness part.
No, I was just wondering because you talked about reduction of travel times, reduction of distances, and people choosing centers that are closer to their place of residence. So do you think it improves, accessibility is the main thing that this program improves?
Yes, ma'am. Yes, ma'am. Definitely.
Okay, thank you.
Thank you, Dr. Sweety. We'll move on to the next presentation by Dr. Achala Regi.
Good afternoon, one and all. So today, the topic for my poster presentation for this session is Dignity in Healthcare Strengthens Equity, Learning Principles from a Psychiatric Case Study. So I would like to give a background to the case study, in which I would like to discuss about two terms. First one is dignity. It refers to how people think and behave in relation to the worth or value of themselves and others. To treat someone with dignity is to treat them as a being of worth in a way that is respectful of them as valued individuals. Second term is standard of care. Standard of care for persons with severe mental illness has limitations in ensuring dignity owing to stigma, stereotype, dysfunction, and poor decision-making capacity found in severe mental illness. This is further magnified among those with severe mental illness from lower socioeconomic strata, yet another social barrier for dignity in healthcare. So, in the light of the background, I would like to present this case report in which Mr. G, a patient of MNC Bagayam, a 42-year-old male who has bipolar affective disorder since 17 years, which is quite a young age. He's also from a lower socioeconomic status with no permanent residence. And adding to the complexity of the situation, his mother, Mrs. K, also suffers from bipolar affective disorder. So some consequences of this situation are lack of capacity to make informed treatment decisions, resistance to take treatment, limited social network, including strained family relations, disrupted employment, social rejection, and fear from society. So, standard of care refers to the level of care that a reasonable, prudent person with similar training and experience would provide in similar circumstances. So in this case, standard of care for bipolar affective disorder in Indian setting involves a combination of medication, psychoeducation, and psychotherapy. For Mr. G, the standard of care treatment scenario can be challenging, attributable to the consequences listed. So the efforts to provide psychiatric support through other means, including rehabilitation, were also challenging, since the reach and consistency of those services cannot always be guaranteed. So provision for care for Mr. G was done in the following ways. Mr. G and Mrs. K, who is the mother of Mr. G, was provided standard of care for bipolar affective disorder like anyone else. And however, their needs were not limited to standard of care. Rather, standard of care failed to meet all their unmet needs. Also, requirements extended from meeting basic needs to a dignified community living. So in order to tackle those, a multidisciplinary team from the department got involved in their situation. So this was met in 4 different ways. So the first one is meeting basic needs, initially through daily supervised drug administration symptom control was achieved and the finances for the same were met. Meanwhile, arrangements for regular food were taken care of. And as you can see in the picture, this was the state of housing and the accommodation of Mr. G and his mother. So they couldn't stay there anymore. So they were given accommodation at a safe place where both of them could stay together, where more of a home atmosphere was provided for both of them. So the second way the team supported Mr. G and the family is in achieving financial independence by empowering him through life skill training and opportunities for gainful employment. So as you can see in the picture, he was trained to make paper bags, which helped him sustain himself financially. And also social benefits such as travel pass and disability pension were processed under the initiative of the team. Also, Mr. G used the regular income to pay for his stay and buy provisions or spend of his choice to support his mother. The third way the team supported Mr. G was through re-establishing social inclusion. Family members who were in a strained relationship were brought into the discussion, thus improving the social network. So as you can see in the picture, he and his mother were together called to celebrate his birthday like anyone else's, and he felt socially included. So shelter, financial independence, social network, and social life provided him with respect, confidence, and self-worth. And this would have imparted him with self-esteem and self-actualization. The fourth way the team supported him was through bereavement support when his mother passed away in 2023 following age-related frailty. He was supported by the team during the funeral. The entire team went to the funeral site and grieved along with him. And he was provided with continuing support to overcome the emotional impact of his personal loss. In the light of the case study discussed above, we can see that a personalized treatment plan ensured regular follow-up and better treatment adherence. Standard care only requires that access to health care be provided and their illness be treated according to accepted guidelines. By taking extra measures to uphold the dignity of Mr. G and Mrs. K, the concept of equity in healthcare was realized among them. This approach ensured dignified living for both Mr. G and Mrs. K. So, our conclusions from this case study and the discussion is: providing care for a poor person with severe mental illness can be challenging. Standard care, while ensuring evidence-based practice, has certain limitations in certain circumstances. Approach laden in valuing and upholding the dignity can ensure better treatment adherence. And we recommend that there should be conscious efforts from healthcare providers to uphold dignity of persons with severe mental illness from a lower socioeconomic background. These are my references. Thank you.
Sure. So I was saying that it's really commendable that the entire team did the extra mile of taking care of the patient and his mother. And while it's really commendable that it could be done for one patient, like you had mentioned, it is very difficult to take care of a poor person with severe mental illness. So on a larger scale, if you were to frame policy or to give an input regarding how poor people with severe mental illness can be cared for, what would be your recommendations be to do it on a larger scale?
For doing it on a larger scale, the limitations of the patient can be assessed by a social worker, or it can be assessed by the hospital itself as to what are the limitations of the patients. So according to that, like it could be financial, it could be accommodation, it could be travel issues, it could be several other issues. The specific problems can be assessed, and how much ever the team could manage, those things could be provided after setting up, if we have a multidisciplinary team in the hospital. So setting up such a team is important in a tertiary care setting.
Probably it is important in other levels of care as well, not just in tertiary care, but in primary and secondary care as well. And also, I wanted to ask on clarification. You mentioned about directly observed treatment. So, how was that ensured? As in the details of how was that done? Patient was not in the hospital, right? He was at home.
Yes, sir.
So, who was ensuring that he was taking the medication?
So the team would go there and ensure that the patient receives medications at a regular intervals.
Okay, so it was a social worker or some person from the treating team who used to visit his home on a regular basis.
Yes, sir. Yes, sir.
Do you think this standard of care program is feasible to be replicated into the primary healthcare system?
I think a primary healthcare center, a primary healthcare system would be able to do it more, because it's more in touch with the community and its needs. So they'll be able to sense it better, and will be able to equip us, a team for it better than any other place. That's what I think.
I have one question. Did you, in your research, did you explore decentralizing this mental health and psychosocial support program, or the standard of care for severe mental illness program, to the community? Identify key community leaders in the community that can check up on these people and empower them. Basically, what you guys did, helping them economically and helping them be financially independent. Do you think it is possible that it can be decentralized to the community so they can have ownership of their own problems and take care of each other without having to rely on formalized Ministry of Health services?
Yes, ma'am, I do definitely think it can be decentralized. Like the scheme of ASHA workers and all had come, like people who don't have an employment but are ready to do something, especially for the community. Such people could be trained for such a thing and employed for the same.
Any question from the online viewers? If not, with that, we have come to the end of the session. I'm sure we had an excellent set of presentation based on the theme equity in healthcare. I would like to appreciate all the participants for their excellent presentations. I would also like to thank our judges, both Dr. Sebin George and Dr. Shaini Kaki, for taking their time and coming and moderating the session and giving their valuable comments. I would also like to thank the audience who are present here, as well as the online audience for attending the session. So the recipient of the Equity in Health Presentation Award will be announced on the final day of the conference. So thank you once again and good afternoon.